Good morning. Welcome back to Cardiology Grand Rounds. So today I'm delighted to be able to introduce one of our very own, Dr. Farid Moussavi-Harami. He's a stellar example of one of our own homegrown physician scientists here in the Division of Cardiology. And so briefly, Farid's background, he did most of his training in Iowa, including undergraduate medical school internal medicine residency training. Then he came to Seattle in 2009 for his combined cardiovascular and research training. Since joining the faculty here in 2013, Farid's been remarkably productive with over 20-some publications and some of them in very high-impact journals like Cell and PNAS. Farid's been incredibly well-funded also with extramural funds from both the American Heart Association and the National Institutes of Health, including now with his own independent research funding in NIH R01. Along the way, Farid's received multiple awards, including first place at the Northwestern Cardiovascular Young Investigator Forum. And truly, Farid has been a rising star and has been incredibly successful. And so I think I speak for not only myself, but all the other junior physician scientists in the division that we look up to Farid for both his inspiration and as a role model. So today, I'm delighted to be able to hand over the mic to Farid for today's Cardiology Grand Rounds.
Thanks, Daniel. Very kind introduction. And yeah, it's great to be back. Last week was my first time in this room, I think in more than 2 years. So it was great to be back, and I'm happy to share some of the work from our group and kind of give an update on the state of the field. As most people know, our research group is interested in sarcomeric biology and in the context of, mostly context of genetic cardiomyopathies. Thanks. Are my disclosures. These are the objectives for the talk. So we're going to talk about dilated hypertrophic cardiomyopathy. We're going to talk about genetics and pathogenesis and talk about some mechanism and clinical data for sarcomeric modulation in these conditions. I'm going to start with a couple of cases that were generously donated by Dr. Savla here, who's in the audience. So first case is a 47-year-old woman with strong family history of dilated cardiomyopathy. Here to discuss screening and treatment. She's asymptomatic and exercises 6 times a week. The family history is significant for dilated cardiomyopathy in multiple generations, including father, paternal aunt, first cousin, and paternal grandmother. And we do have a genetic testing available from a paternal aunt, which is which identified a pathogenic variant in the gene Titin. In terms of social history, she's a non-smoker and real alcohol consumer. In terms of, when she presented to clinic, she had echocardiogram performed, and hopefully you can appreciate that this ventricle is dilated and it indexed at 84 mils per meter square and had moderately reduced systolic function. There were no other abnormalities identified. She underwent genetic testing, and I guess this is an advantage of knowing what gene you're looking for. So she underwent genetic testing just at the Titin gene, and she had the same variant as her aunt. So this was a pathogenic variant in Titin. So we have a diagnosis for our patient. So she has genetic dilated cardiomyopathy secondary to variant in the gene Titin. The question then is, what are some treatment options for a patient like her? And I will come back to this at the end of my talk. The second case I'd like to share with you is a 45-year-old woman who has history of hypertension and was referred to cardiology after having an abnormal ECG. She reports some exertional dyspnea, but no other symptoms, no palpitations, no heart failure symptoms. She has a family history of sudden cardiac death in her maternal grandfather, and her son is reported to have a systolic murmur. This is the ECG. Hopefully you can appreciate. You can see that it's sinus rhythm with its lateral T-wave inversions. And she underwent an echocardiogram as well. Sometimes I'm impatient. So hopefully you can appreciate the hypertrophy here at the septum, and there seems to be some systolic anterior motion of the mitral valve as well. The gradients in the LVOT, they're elevated at 103 millimeters of mercury at rest, and in Valsalva, they go to 111. I didn't show you all the images for this echocardiogram for sake of time, but we saw that the maximal wall thickness was 15 millimeters in the mid-inferior septum. That it was diastolic dysfunction, elevated filling pressure, the LVOT gradient was elevated, and there was some mild pulmonary hypertension. She underwent a cardiac MRI, and this essentially showed some of the same findings in terms of asymmetry of the septum, and additionally showed some late gadolinium enhancement indicating fibrosis in the heart. So our diagnosis is hypertrophic cardiomyopathy. She underwent genetic testing, and there were no pathologic variants identified. She was initiated on metoprolol with some mild improvement in her symptoms. Calcium channel blocker was added, but she didn't tolerate it. So we are, I guess, 2 years past initial diagnosis. She's still having class 2 symptoms with a gradient that's more than 100 millimeters of mercury at rest. So the question for this case is, what will be the next step in management? And I'll come back to this HCM case at the end. This is going to be the outline of the rest of my talk, and I hope to discuss with you clinical presentation and genetics of cardiomyopathies. I would like to discuss pathogenesis of sarcomere genetic cardiomyopathies, and then focus the rest of the talk on how we can directly affect the sarcomere for these conditions. And hopefully the goal is to share state of the field and then just showcase some of the work that we do in our group. So I'm going to start with discussing clinical presentation and genetics of cardiomyopathies. So that we're on the same page. Cardiomyopathies are a heterogeneous group of heart muscle disorders that result in heart failure. They are morphologically subtyped into hypertrophic cardiomyopathy, like the second case I discussed. The prevalence is about 2 to 5 in 1,000. Dilated cardiomyopathy, like the first case I discussed, the prevalence originally was thought to be 1 in 2,000, but in more recent contemporary data, it seems to be more like 1 in 250. Other rare subtypes are arrhythmogenic, LV non-compaction, restrictive cardiomyopathy. For my talk, I'm just going to talk about the first 2 here. As hopefully most of you know, hypertrophic cardiomyopathy is unexplained hypertrophy with decreased chamber size. The ventricle is hyperdynamic, has diastolic dysfunction. Patients present with shortness of breath, chest pain, arrhythmia, and can have cardiac arrest. In terms of treatments, beta blockers, calcium channel blockers, disopyramide can be used in obstructive patients. And if they don't respond to medical treatment, myectomy and for arrhythmias, ICD and then heart transplantation. And most recent addition to our treatments is the myosin inhibitors, which are first in class FDA approved earlier this year. And I'm going to talk about what those drugs do and some of the mechanisms later in my talk. So for dilated cardiomyopathy, as hopefully most of you know, and it's shown in this picture, the ventricle is thin, the ventricle wall is thin, and the chamber is dilated, hypercontractile. So this is in absence of other conditions, so no myocardial infarction, no malformative disease, no toxins, no other causes. And then patients usually have can be asymptomatic, or they can present with heart failure type symptoms, shortness of breath, pulmonary congestion, etc. The therapies are currently similar as what we do for other heart failure conditions. So beta blockers, MRA, ACE inhibitors, ARB, neprilysin inhibitor, and most recently SGLT2 inhibitors. Our advanced therapies include LVAD and heart transplantation. And hopefully in the near future, we can have medications that directly affect the sarcomere, so myosin and troponin activators. And I'll show you some of the data and mechanisms of such drugs. In terms of genetics of hypertrophic cardiomyopathy, they're autosomal dominant with variable penetrance. It is familial in almost 60% of the patients. And it's very important to remember that this condition is really disease of the sarcomere. And I have a picture of the sarcomere here. The top two candidates are myosin binding protein C, myosin, and then the other sarcomere protein that's affected are troponin and tropomyosin, which are part of the thin filament. So hopefully you remember some of these names as I go through the sarcomere structure later in my talk. For DCM, it's a different picture. You can find genetic causes in half the cases, but it affects the sarcomere, but it also affects other parts of the cell. So our group is interested in the sarcomere, and some of the genes and candidates are here, but you can have a variance in genes that code for proteins in the nuclear membrane, the lamin AC, this RNA binding protein, RBM20, desmoplakin, which is cytoskeletal. You can even have ion channels. And these are just a few examples. Now, interestingly enough, genetic cardiomyopathies or variants in sarcomeric genes are being recognized in even acquired conditions. So this table is from a study that did genetic testing on what clinicians thought were cancer therapy-induced cardiomyopathy. And they compared them to non-cardiomyopathy cancer patients and healthy subjects. And they used the cardiomyopathy gene panel, and they picked up variants in 12% of the patients, which is significant, much more significant to the other two control groups. And most of the variants they found were truncating variants in Titin, which is a leading cause of dilated cardiomyopathy. The same kind of study has been replicated in alcohol-induced cardiomyopathy and peripartum cardiomyopathy. Next, I'm going to move to pathogenesis of sarcomeric genetic cardiomyopathies. Now, in order to understand or better understand the process involved here, it's good to know what the sarcomere consists of. So sarcomere is the basic unit of contraction. It consists of thick filament, which has myosin and myosin, which has myosin with the myosin motors. You have the thin filament, which is actin in green, tropomyosin in purple, and the troponin complex. You also have myosin binding protein C that spans the two, and Titin provides elasticity of the sarcomere. And when contraction occurs, you essentially have your myosin heads interacting with actin, ATP binds, and the cycle goes over and over many, many times throughout the life of a person. In terms of pathogenesis of genetic cardiomyopathy, so I'm going to talk about the genes that are commonly affected and what's currently known about mechanism. So the thin filament, mostly consisting of variants in troponin and tropomyosin, is involved with both hypertrophic and dilated cardiomyopathy. And the primary, and these are usually missense mutations, so point mutation. And the primary mechanism is altering the wild or the wild type function. So either the filament becomes less or more sensitive to calcium. Myosin binding protein C is the leading cause of hypertrophic cardiomyopathy, and they're usually frame shift mutations that reduce the quantity of myosin binding protein C. So it's the mechanism is thought to be haploinsufficiency. Titin, which is this orange color here, it provides elasticity in the sarcomere and is the leading cause of dilated cardiomyopathy. And the mechanism wasn't really clear until there were two papers last year that definitively showed that both the haploinsufficiency and a truncated protein are involved, which so both of the mechanisms that people thought were plausible occur in patients with dilated cardiomyopathy. In terms of the other gene that's involved, the myosin heavy chain NYH7, the variants can cause both DCM and HCM. It is the second leading cause of HCM. And the current thinking is that these variants interfere with the primary function of myosin motors, either decreasing the number of myosin heads or altering its function. I do have to say that Daniel is an expert on myosin, so that's what his lab studies. So I'm sure we'll hear from his work sometime in the next year or two. So our group has been interested in pathogenesis of cardiomyopathies for some time. And this paper, which was in collaboration with the investigators in UW bioengineering, we showed that, that what is predictive of cardiomyopathy phenotype is this idea of looking at force over time and looking at the area of this twitch. So the twitch, it means the information of, it is a plot of force over time. And I'll kind of walk you through this. So if you think of a control or a normal patient situation as this black area, this black curve, if you have a condition where your twitch area is higher, then you are in a hypercontractile situation and you're more likely to be HCM. If the area under the curve compared to this control situation is negative or less, you're more likely to be a dilated cardiomyopathy. And this was, in this particular paper, these were computationally derived from data, experimental data, and they were validated independently in all the mouse lines shown here, and 4 cell lines from from patients with dilated hypertrophic cardiomyopathy. So we feel like this is a very nice predictor to if there's a variant, to know what the phenotype would be in the whole organ. So I'm going to go back to this image and now just talk about one thin filament variant that we have studied that I partially presented last time I gave ground rounds, but now it's been published since then. So this thin filament variant is in the gene tropomyosin. So this purple line here, tropomyosin's function is regulatory protein of contraction. This particular variant was identified in 2 unrelated families of dilated cardiomyopathy, and having this variant in your sarcomere affects function, and there is a transgenic mouse model that has been created and shows similar phenotype, and that's what we used for our studies. So this is, I guess, the first piece of data from our group. So this assay I'm going to show several times in my talk, so I'm just going to spend some time. I'm going to spend some time explaining it. So these assays are actually the person who does it in the audience in the back, Dr. Koiker. We take pieces of trabecula, which are these linear areas in the heart or papillary muscles. We get rid of the membrane so we can control the external calcium. You put it in a, you then attach it to a force transducer, to a force transducer and motor. You fix the length and you go from low to high calcium concentration as shown here. And as calcium increases, the amount of force that it generates increases. And when you are done with your experiment, you analyze this data by plotting how much force was generated and normalized to the area of the prep versus calcium. And now we use PCA, it's like a pH. So you have to think of the higher the calcium, the lower the number. And I have indicated this here so we can remember. So you go from low to high calcium and the force increases. And this, hopefully you can appreciate that these two curves are different. So this means that at the same calcium level, the green, which is our dilated cardiomyopathy model, generates less force. And we have to be able to quantify things. So this is quantified by a measure called PCA 50. So what is the PCA that gives you the half of your maximum force? So this is called PCA 50. And the two numbers are different, as expected, 5.58 versus 5.35. So you have to think of it that this 5.35 means you need higher calcium to get the same amount of force. Now, I told you that in our cell paper that this idea of area under the curve of twitch was important. So how does one get that experimentally? So again, these same kind of linear areas in the heart is dissected out, but this time we keep everything intact, have a motor and a force transducer, and then just pace it. And the data would be, again, twitch force, so force over time. And here in this situation, we've normalized it for our control. So you can see that the twitch is smaller. And by definition, this matrix is area under the curve or tension index. Your control situation is 0, and then you're either negative or positive. And here we are negative. So we go back to our metric here. So you expect to have DCM. And it's not surprising, right? The variant was identified in patients. So you made a mouse, and it shows the same phenotype. And this is the echocardiography. So hopefully you can appreciate that this is, let's see. Let's go back. Let's see. I guess it does not want to play. So this is the normal mouse hearts, and the one here is more dilated or hypercontractile. So this, as the mice age, the ejection fraction is lower, and the diastolic diameter is enlarged. So this is consistent with the DCM model. So I just wanted to give a flavor of how we think about cardiomyopathy and some of the tools in the lab, but we have other models that we're currently studying too. So next, I'm gonna give an overview of the sarcomere and then move on to sarcomere-based therapies. If you remember, I showed you a picture of the sarcomere, and this is then how contraction happens. And I think we all have learned this at some point. It is in Braunwald. I did check that. It is not as nice as this figure, but it is in Braunwald's book. So when you don't have, so in order to have contraction, you have your myosin be primed and ready. So the energy comes from hydrolysis of ATP. So your myosin is ready here, but unless you have calcium, you won't have contraction. So when you don't have calcium, the tropomyosin is in a blocked position. So the myosin binding sites and actin are not available. When calcium binds, then you have your tropomyosin go from blocked to this close state, and you have some initial weak binding from your myosin, and that allows the tropomyosin to move to an open position. So you can see it moves from here to here, exposing these sites, and you have more myosins bind, and then you have your power stroke. That's how force is generated, and then you have release of your product, phosphate, ADP. And then these two will let go when the next ATP comes. Now, it turns out, I think, like I said, most of us learned some version of this. It turns out that this part here is more complicated than originally thought. So myosin is not all myosins that are in off states are the same. And this has been, I guess, described in the last 10 or so years. So So if your myosin is bound to actin, it hydrolyzes or uses ATP very fast. If you're not, it turns out that you can have two states. You can have something called the disordered relaxed state and a state called the super relaxed state. And you'll find out why these things are important later as I get to the therapies. So when myosin is bound to actin, you hydrolyze ATP very fast because you have to have contraction occur very fast. Now, in these two states, that's the green here. So this is energy utilization of ATP over time. Now, this disordered relaxed state is 100 times slower. That's this one's here. You can think of it as the myosins are a bit more primed to interact with actin. But if you're in this super relaxed state, you're even tenfold slower in utilization. So if we then put this new concept to what we learn in medical school, then you come to here. So in order for myosin to be involved in contraction, you got to be here, but to get there, you have to be in this disordered relaxed state. So SRX, DRX, and then active myosins. And this is important because people have shown that this how much of this SRX, DRX you have is actually altered in hypertrophic cardiomyopathy. So the thought is that you have more of this disordered relaxed state. So there are more, and that's why you have hypercontraction as in some of the myosin HCM variants. So now that we have a framework, so we have sarcomere and we know cross-bridge cycle, we get to our therapy. Now, people have been working on directly affecting the sarcomere for 2 to 3 decades. But fundamentally, you can either make the thin filament more sensitized or less sensitized to calcium. An example, so similar to our tropomyosin variant, it was a desensitizer, but you can have drugs that do that as well. This approach hasn't been that successful to make it to the clinical realm so far. Or you can affect the motors, the myosin motors, either activate them or deactivate them depending on the condition. So you're activating if you're treating a heart failure and inhibiting if you're treating hypertrophic cardiomyopathy. So now where are we with myofilament-based interventions? So in terms of inhibitors, mavacamten is first-in-class FDA approved. Dr. Owens and Savla tell me that we have somewhere in order of 20 patients on mavacamten here at the University of Washington. The next drug in the class is called aficamten. And this drug is in phase 2-3 for hypertrophic cardiomyopathy. The two clinical trials are Redwood HCM and Sequoia, and I believe that we are a site for Sequoia. On the activator side, omecamtiv mecarbil is in phase 3 for chronic heart failure. The study at Galactic HF was, I believe, presented at AHA last year, and I'll show you some of the data. The next in that class is danicamtiv. It's currently in phase 2 for heart failure with reduced ejection fraction. And I will share with you some of the data from our lab in terms of mechanism of that drug. I'm not going to talk about troponin modulator, just to mention that the only troponin modulator that has made it far in other countries is levosimendan. It's a calcium sensitizer that works on troponin C. The clinical trial in the United States, they were called Revive 1 and 2 for acute decompensated heart failure, and it was a neutral trial and was not approved here in the United States. There is another compound from Cytokinetics that's in preclinical phase, and the study for that was in circ heart failure earlier this year. The drug is called CK-136. So now I'm going to discuss sarcomere inhibition for hypertrophic cardiomyopathy, and that's really what has brought a lot of excitement to those who take care of the patient, as well as those of us who study this in the lab. So mavacamten is the first in class. This is a small molecule that binds to myosin. And the way these drugs were found were they screen compounds that would inhibit the ATPase function of myosin. I showed you those curves of use of ATP. So this is a rodent myofibril, and they're measuring how much ATP is consumed. And you can hopefully appreciate that this is the level of the drug. The more of this mavacamten you have, the more ATPase is inhibited. So that's one mechanism. I told you about this concept of the SRX-DRX, and this compound modulates that. So this is a this is a slide. This is a figure from a paper from my mentor that has looked at this in human myofibrils from human iPS cardiomyocytes. And you can see that, so this is showing the proportion of SRX to DRX in an unactivated situation. So in a low, where you don't have calcium, you can see that hopefully when you have the drug, that you're going from, you have an increase in your SRX population. So I told you that this ratio was affected in HCM, and the drug seems to work on that. Another mechanism is increasing product ADP release and cross-bridge detachment. For interest of time, I'm not including any data, but people have studied these in multiple independent laboratories. So if we go back to our framework, so we have a drug that affects this ratio here. So how much of your, so you're taking the myosins out from the active pool by affecting this. You're decreasing ATP hydrolysis, and then you're having faster ADP release that can promote faster relaxation. Now, how does this look in our experiments? I'll just show you some data from our lab. So hopefully you remember this is our demembranated situation where you have isometric force measurements with increasing calcium levels. No drug is in closed circles, and then mavacamten is in open circles. Hopefully you can see that at each of the calcium levels, you have decreased amount of force. And remember, we quantified this using a PCA 50. So the PCA 50 has decreased. So from 5.7 to 5.56. And I told you before that we really think that twitch is important, or that area under the curve. And this is, again, a mouse trabeculum that we have made measurements of the twitch without the drug, and then increasing concentration of the drug. Hopefully you can see that the twitch is smaller, and there's also some kinetic changes in terms of activation and relaxation. Now, how does this drug look in clinical trial? This is from Explorer HCM, which was a phase 3 randomized trial in patients with hypertrophic cardiomyopathy with a gradient of greater than 50 milliliters of mercury and class 2 to 3 symptoms. You can see here that post exertional LVOT decreased after treatment on the drug. And during the study, there was decrease in resting LVOT over time. And not only there were hemodynamic changes, the patient's symptoms improved. So you can see compared to baseline at 14 weeks, we have patients who have class 1 symptoms, they have less class 2 symptoms, and this continues at the conclusion of the study. Now, not only do patients and hemodynamics change, there's actually remodeling the heart. So this is Explorer HCM MRI substudy that was published in Circulation last year. They took a subset of the patients, and at the end of the trial, they had MRI done. You can see the LV volume, the LV mass index is decreased. Maximal thickness of the wall is decreased. And there's even some evidence of atrial remodeling, and there's decrease in the ejection fraction. Interestingly enough, there was no change in fibrosis as indicated by late gallium enhancement. And the most recent data in this on this drug is was presented, I think, at ESC this year, where this is from Valora HCM, where they took patients that met the criteria for septal reduction therapy. Then they were randomized to mavacamten and placebo, and then at 16 weeks they looked and see, did the patient still meet the criteria for septal reduction? And very interestingly enough, very intriguing enough, that 82% of patients do not meet the criteria for having septal reduction surgery. And in terms of symptoms, same kind of improvement. So the patients improved by at least 1 to 2 class in the mavacamten group, while in the placebo, majority of them had no change in their symptoms. Just a slide on aficamten. I said that it's in a phase 3 clinical trial. The mechanism is thought to be different, but it's unclear what it is doing beyond inhibiting the ATPase activity. Some of the thoughts are that it stabilizes a different state, a distinct off state, but data is not available yet. We're in our groups getting some studies started on that. I've included this slide to show that perhaps the two drugs may be different, and maybe aficamten is going to be the one at the end that's going to be have better therapeutic range. So this is IC10 and IC50, meaning that what is the this is the amount it takes to decrease the fractional shortening. This is in a rat model, I think, if I recall correctly, to reduce from 10% or 50% versus the concentration of the drug in the animal. You can appreciate that it's more flat for aficamten. So the thought is that maybe the therapeutic window is going to be more. And the only other piece of data on this drug was published last month at the end of August in JACC Basic Sciences Translation. This is the first in human, showing that increasing doses at 14 days, and in patients decrease in LVEF as is expected based on the mechanism of these drugs. And there should be more coming into about aficamten in the next year or two. Now, what about sarcomeric activation in heart failure and DCM? So as I mentioned earlier, omecamtiv mecarbil is the first of its group. I remember when this was presented at AHA in 2010, I think, when I was a fellow. It was originally thought to be a myosin ATPase activator, but as studies occurred, it seems to be more complicated. So the current thought is that it is releasing phosphate faster, but most of the effect is from the interaction between myosin and actin happening over a longer period of time. If you look at some of the clinical studies, they quantify this by systolic ejection time, so how long you're in systole. So you're having, if you can think of it as if you have a rope, there's more hands on the rope, so you have more force. And the clinical trial was completed and presented last year at AHA. This is called Galactic HF. And this was a group of heart failure patients with class 2 to 4 symptoms, ejection fraction less than 35%. And the primary endpoint was cardiovascular death or heart failure event. And I do have to say that this was quite underwhelming. So you can see that the p-value is significant, but it is a minimal effect. And then so the cardiovascular death is not different. And then the other primary outcome, heart failure events, are not different independently. There was a sub-study published earlier this year suggesting that they had maybe more benefit at a lower AF, but it's unclear what the role of this drug would be, at least in a standard heart failure population. Now, I mentioned earlier that as all these things go, you have a first in class, and then somebody develops the next one. The next one is danicamtiv. And this is thought to have similar mechanisms, having more myosin heads available, but there's limited data on it, at least published. There is a clinical trial recruiting patients with genetic DCM, and in particular those with Titin and MYH7. And the clinical trial number is here. When I checked last night, they don't report their enrollment, but they have 15 sites, and they expect the study to be concluded in 2025. So in the rest of my talk, I would like to highlight our attempts at studying the mechanism of danicamtiv and showing some of its utility. The idea is to kind of show a framework of how you can study these small molecules and kind of give a little bit of flavor of what our lab study is. So what I'm going to share with you, our objective was to understand what are the effects of danicamtiv on beta myosin cross-bridge cycling kinetics, and then assess the ability for danicamtiv to recover contractile function in a rodent dilated cardiomyopathy model. We use healthy pig tissue. The reason to use for our mechanistic study, the reason to use pig is that rodents have a different isoform of myosin. So and that's why Daniel studies human iPSCs. If you're interested in myosin, you have to you cannot use rodents. So we use pig tissue and our demembrated trabecular assay, which I've shown you a couple of times, and then I'll show you one of my favorite assays, which is in vitro motility assay, where you see these actin filaments that are like worms. And for showing the use in our mouse model, we use again our demembrated trabecula and then the intact, which is both of which I've introduced to you earlier. Again, this is our I think this is the third time I'm presenting this assay. So again, force, calcium, this is drug, no drug. In this situation, we have normalized the maximum for each of them. Again, hopefully you can now get the flavor of how we look at these things. The curve is shift to the left this side, right? Before we had right. So this is, you become more, you increase your calcium sensitivity. And then that's quantified here with an increase in calcium sensitivity. And interestingly enough, that most of your benefit is in the lower calcium levels. And that's interesting because the heart mostly operates in this area. You know, when we go to this very high calcium, these tell you about mechanisms of things, but it's not really physiological. And then we have these maneuvers where we can study how things, get some ideas about mechanism. This particular protocol is called KTR, where when you're at your steady state with the calcium, after your steady state force, you slack to break the cross bridges and then restretch and see how fast things develop. And you can see that the drug actually slows things down. So combination of this and some other assays in our lab suggested that maybe this is a product release is the reason why this drug is increasing force. And to test that indirectly, we use this in vitro motility assay. That I said it's one of my favorite things in the lab. So this is a bed of myosin, and then you have your fluorescently labeled actin, and then if you add the two together, and then when you add ATP, the worms move around. And you can see that the filaments are slower with the drug. So you have a camera and you measure how fast the worms go. Now, I told you that we thought that this was from ADP release. So if you think of the reaction, so we have added our ATP here, your cross-bridge cycle goes, I put the end here, you have actin, myosin, ADP, and then the ADP is released. So if you want to test out to see if this is the mechanism, is the decreased rate of this, what you can do is you can increase the concentration of this and then push the reaction backward. The expectation would be that you should have even less filament velocity, right? If you don't have the drug. And I guess the question is, what happens to the danicaptiv? And when we did that, you can see that the two look the same. The idea is that danicaptiv slowed the filament velocity, when you increase the ADP, the ones for danicaptiv are already slow, and they couldn't, you couldn't push it back anymore. So this is an indirect measure, an indirect idea of how this drug works. I guess I failed to mention that we looked at phosphate release, and that was not effective. Because I said that we're thinking it was is a product release. So to put this, what I showed you about this drug, so I showed you that ADP release is affected, and for the sake of time, I did not show this data, but we have data that we're affecting this GRX. So you're priming the myosins to be involved in contraction. So these are the two mechanisms that we have right now for this, this drug. And what about utility? So again, same assay. It's the fourth time showing this for calcium. Green open triangle is our tropomyosin mouse without the drug. When you add the drug, you're in this closed triangle. So you shift it back to the normal. Just for completeness, we took the control mice and added the drug to it. It also shifts. Again, the quantification was this PCA 50. So it's lower here and it's increased. And there's no difference between the treatment group with the drug and the non-treated controls. And then what about this area, this twitch that I've been telling you about? This also is recovered. This is an average tracing of 4 or 5 experiments, independent experiments. So our, again, D230N tropomyosin has the twitch that's smaller with a smaller area under the curve compared to your non-treated. When you add 1 micromolar of the drug, you can increase. The drug also works on the control. You can see that there's some subtleties here that you're affecting contraction, but you're prolonging relaxation. So all these drugs, you need to get I think the sweet spot of the level. And then we can quantify these. This is our peak, our peak tension measurement. It's decreased in our D230N without the drug. And then we can recover it with 1 micromolar, 3 micromolar. And I showed you that tailing and extending of the relaxation. There seems to be ever so slightly at 1 micromolar increasing your relaxation time. So this is time it takes to get 90% back down from your peak. And you can see it's increased slightly here and much more at 3 micromolar. So that just gives you a flavor of what we study in the lab, and we're doing the same thing with the myosin inhibitors, and this in theory could be added, could be studied on any of these small molecules. So back to our cases I presented at the beginning. This is for the Titan genetic BCM patient was started on heart failure treatment with improving cardiac function. I guess she could potentially enroll in that danicaptiv trial, but I would say the data on the myosin activation is still investigational and under and hopefully would there'll be more data in its use in patients. In terms of the symptomatic obstructive HCM patient was initiated on mavacamten, and I just included this so that people know that these drugs require a lot of effort and infrastructure that Dr. Savla and Owens have established here. You have to have the drug started. You have a baseline echo, 4-week echo, 8-week echo, and then there's all these algorithms in what happens to the LVOT, what happens to your EF, those adjustments. So it is quite involved to have, and the reason is that this is what was used in the study. So the FDA has approved it using these kind of algorithms. I think we're making good time. I would like to conclude that sarcomeric variants can result in genetic cardiomyopathies. I showed you that cardiac tension predicts the phenotype of the cardiomyopathy, and we can use sarcomeric function modulation to recover abnormal tension in cardiomyopathies. myosin inhibition is recently approved for symptomatic obstructive HCM. I showed you some mechanistic study. I showed you the clinical data. And myosin activation may be a treatment for genetic DCM. And I highlighted how you can use biochemical and biomechanical assays to tell you about mechanisms of sarcomere modulators or diseases. For future studies, we're actually directly going to measure ADP values for danicamtiv. We're comparing aficamtiv and mavacamtiv in the lab. And we're in the process of trying to see if you have a genetic DCM, does it make a difference if you activate myosin or troponin? And there's a portion of our lab that does computational simulation to come up with best treatments. I would like to acknowledge my lab and collaborators. So Dr. Koiker is a scientist in my lab and is here in the audience that does a lot of the mechanical experiments. We have students that help in the lab, especially doing some of our stop flow assays. My collaborators in bioengineering and my mentor, Mike Rainier. And the mouse data I showed, it's from Dr. Tarda from University of Arizona. And I would like to thank Dr. Savla and Owens, who always give me inspiration for what we do in the lab, since they take care of the HCM and DCM patients. And somebody has to pay for the work. So NIH currently pays for a lot of our work from our current grant and previous grants. We also are fortunate to have an American Heart Association Collaborative Sciences Award. And I think that gives some time for some questions. I guess for the Zoom people, they can put it in the chat. I don't know what the chat means. Did I do it? Oh, wait. Oh, sure. So yeah, Chananda, yeah. Oh, great question. Chananta, you should come to the lab. So Chananta is asking, how does one measure the SRH versus the? That's a great question. So people have used biochemical assays. So we have you can have an ATP that's fluorescent. And so what you do is you know, those curves that I showed, you can have you essentially have to have a reaction that happens. So ATP turnover is very fast. So you have a chamber, you load with this fluorescent ATP, then you have a dark ATP, you push against, and then the two very fast, and you look at the decay. So then you see this fast decay, which you see two phases, a faster one and a slower one, and then you see what you kind of get a ratio of the two. Now that's a chemical. If you remember, the top figure also had the myosin heads, right? That, you know, how close the myosins are to the thin film, and you can use X-ray diffraction, and we have studied using that, but you know, that requires going to Oregon National Laboratory, which our team goes once every 6 months. So we have some of that data on danicamtiv and some of it on aficamtiv, but that's a great question. Yes, great.
Given your ability in your lab to look at the mechanisms for dilated and hypertrophic cardiomyopathy, do you have any insights into why it presents in
That's a great question. So, you know, there's several thoughts on this. Some people think that maybe you have a predisposition and you get a second hit. You know, we haven't looked at that directly. We're collaborating with folks that have using the same kind of with mouse, and then try to put the mice on high-fat diet, make them hypertensive, and see if acquired conditions make that come out. For, you know, for HCM, there's some data from the Sideman group at Harvard. We did a twin study where people have the same variant, and then they have different phenotypes. So there's definitely thought that there's external factors that do that, that modulate it. But that's a great question.
Farid, I've got a quick question.
Yes.
Thank you for the outstanding talk. It was quite impressive. You spanned a very wide spectrum from HCM to DCM. My question revolves around mavacamten. So like you're aware from HCM registries, there's some suggestions, at least from the SHARE registry, that patients with sarcomere mutations have worse outcomes. Do you know if mavacamten's beneficial effect, if that's dependent on mutation status?
That's a great question, Daniel. In the Explore HCM, if you look at the subgroup, there's a gradient. The patients that have a gene positive had the most effect, then the variant of unknown significance, and then people who are genotype negative. So the thought is that probably the most benefits is for genome positive, and the VUSs have a mixture of some are pathogenic and some not. So that's right. Let me just, there's a question in the chat. Oh, Mel Thompson, that's a great question. So Dr. Thompson is asking me, do they affect skeletal muscle? So these drugs are screened so that they don't. It actually, it's an interesting question. We actually tested this by accident 2 weeks ago. Our student came to me and said, oh, we're looking at danicamtiv, it doesn't work. I'm like, oh my goodness, it's not good. So it turned out that, we had skeletal muscle myosin, and yes, so it definitely, they're screened in a way that not affects muscle myosin, because the isoforms are different. So yeah, I can say for sure on danicamtiv it has no effect on skeletal myosin. Yes, Jay. Mm-hmm. It's a good question. I mean, the drug definitely works on myosin, but I think what you're bringing up a good point is what is the interplay between the fibrosis and the cardiomyocyte? I mean, that part's reversible, right? Because fibrosis is made by fibroblasts. So now we are fortunate at the University of Washington to have one of the best labs that studies fibroblasts. So we collaborate with them. So I know a lot about this topic, but we don't do the study. It's very interesting. So we are collaborating with Dr. Davis, who's the investigator here, and it's very interesting. So they have used a troponin dilated cardiomyopathy model, and all they did was they modulate fibrosis, and they got improvement of the phenotype. Interestingly enough, they also modulated the troponin and got improvement of phenotype. So it's interesting. So there's definitely interplay. So fibrosis is very important. Dr. Savla and Owens know this. I mean, the fibrosis can stratify the patients, right? It actually it's genetic and even in acquired conditions. So fibrosis is very important. And we currently don't have a drug that affects fibrosis. I guess losartan kind of, right? There was this trial of, yes, but I don't know. Yes. Yeah.
Follow up on that. I mean, what's the 2020 trial?
I guess for people on Zoom, I didn't repeat Dr. Mayfield's question. It was about fibrosis and Explore HCM. And then Dr. Owens commented that it was a small subset, so it's hard to know, and short duration.
We're super excited. The data right now is really focused on reducing contraction obstruction. And our experience thus far is quite favorable. We've had a number of patients who completely lost their obstruction on the first 5 milligrams. So many so that we're having to down titrate the drug according to the algorithm and things like that. So we're excited about that. But I think the bigger population, I think the biggest benefit we might get from this might be in the non-obstructive hypertrophic cardiomyopathy. They had a phase 2 trial called Maverick that showed a 50% reduction in 70% reduction in EMP levels, a reduction in troponin, and things like that. And my question is, what do you think the mechanism of benefit is in there? And do you think that speaks to the ability of the drug to perhaps alter the natural history of the disorder?
So for people on Zoom, Dr. Owens is bringing up the question about non-obstructive patients. And there's the Maverick trial showed that there's a benefit in non-obstructive patients. And the question is about mechanism and thoughts about, and what do we think about that? So I think there's data that mavacamten affects relaxation. And I think that's probably where the benefit is, because the SRX-DRX is only in the activated part. But if you're relaxing faster, there's data from multiple laboratories showing that the relaxation phase is affected in hypertrophic cardiomyopathy. And so I think it's faster cross bridges detaching and then ADP release faster. So kind of opposite to what I showed for the danicamten. We are going to make those measurements in the lab. We just haven't done that yet.
Okay, well, great. Oh, we may have one more question. Do we have time for this?
Dr. Kapoor asked, do you think that all cardiomyopathy we think are provoked should undergo genetic